Good afternoon, students. Our today's class is on the anatomy of prostate. The learning objectives for my today's class are: I will be describing anatomy of prostate under following headings. Definition of prostate: it is location in the male pelvis. Borders and surfaces of prostate with its relations to the surrounding structures will be described in detail. I will be also describing lobes and zonal anatomy of prostate. Will describe capsules of prostate gland and will compare it with the capsule of thyroid gland. Arterial supply, venous drainage and lymphatic drainage will be also described in this lecture. We will also describe innervation and applied anatomy of prostate. Prostate is defined as a pyramidal fibromusculoglandular structure which surrounds the prostatic urethra from the bladder base to the membranous urethra, and is itself surrounded by a thin but tough connective tissue capsule. As shown in this diagram, prostate is pyramidal shape with the base applied to the neck of the urinary bladder and apex which rests on the urogenital diaphragm. It is traversed by the prostatic urethra which is surrounded by prostatic tissue, and the prostatic tissue itself is enclosed in prostatic capsule. The shape of prostate is pyramidal, or it is conical in shape with its base applied to the neck of the urinary bladder and its apex resting on urogenital diaphragm. The size of prostate is equivalent to that of a chestnut. Dimensions of prostate vary with age. At base it is 4 cm in transverse diameter, about 3 cm in vertical diameter and 2 cm in anterior-posterior diameter. It is easy to remember: 2 by 3 by 4 cm. Weight of the prostate 15 grams in young adults. Enlarged gland may weigh up to 150 grams. Enlarged prostate may be due to benign hypertrophy of prostate, which is the commonest cause in the first 5 decades of life, or it may be due to malignancy of prostate. Weight in living. In this class, I want to clear some doubts of prostate. We say the weight of the prostate is 15 grams. This is the anatomical weight of the prostate. The prostate in living is 18 to 20 grams. As already said, prostate can enlarge in benign and malignant conditions, so its weight increases and it can go up to 150 grams. We can detect the weight of the prostate by using ultrasonography in living anatomy, and we divide the enlarged prostate into various grades depending on its weight. Grade 1 prostate is when the weight of the prostate is up to 25 grams. In grade 2 prostate, weight is up to 50 grams. In grade 3 prostate, weight is up to 70 grams. In grade 4 prostate, weight is up to 80 grams. And in grade 5 prostate, weight of prostate is more than 80 grams. Again, I want to make it clear, cadaveric dimensions are always different from the dimensions in the living. Parts of prostate. Prostate has a base which lies at the bladder-prostate junction, as shown by this black dotted line. It has an apex, which is the narrowest and most inferior portion of the gland. Apex sits on urogenital diaphragm, again shown by this black dotted line. Palpation of the prostate can be done on a mannequin or in a patient or in subjects. This procedure is called DRE, or digital rectal examination. What is DRE and which structures we can feel on DRE? DRE stands for digital rectal examination. In a clinical setting, the anterior structures which we can feel on DRE are prostate, seminal vesicle, base of urinary bladder, and rectovesical pouch. Posteriorly, we have rectal wall, lower parts of sacrum, coccyx, ischial spine, and tuberosity. Prostate has anterior surface, posterior surface, two lateral surfaces, and a base, superior surface, which is also called base of prostate. What are the relations of the prostate with the surrounding structures? Let us go to the relations of the anterior surface of the prostate. Anterior surface of the prostate lies posterior to the symphysis pubis. Precisely speaking, posterior to the inferior part of the symphysis pubis. It is separated by retropubic fat in the retropubic space, which is also called cave of Richius. It is supported by puboprostatic ligaments. Now in this diagram, this black dotted line represents the anterior surface of the prostate. Arrow represents posterior surface of pubic bone. Retropubic space is called retropubic space of Richius, which contains fat, venous plexus, and puboprostatic ligament. Posterior relations of the prostate are: posteriorly it is related to the anterior surface of rectal ampulla. The two are separated by rectovesical septum. Rectovesical septum is also called fascia Denonvillier. Superior relations of the prostate. Base is also called superior surface of the prostate. It is related to the base of prostate is continuous with the neck of the bladder, the smooth muscle passing without interruption from bladder to prostate. As shown in this diagram, urethra enters the center of the base of prostate. Relations of the lateral surface. Lateral surface of the prostate. The lateral surface of the prostate are embraced by anterior fibers of levator ani muscle. Levator ani muscle forms the pelvic diaphragm. Let us go for a pulse session to discuss relations of the prostate. You will have to identify the different structures which are given in the diagram. So this yellow dotted line represents the base of the prostate. It is superiorly related to neck of the urinary bladder. Again, this dotted line represents apex of the prostate, which rests on urogenital diaphragm. This line represents prostatic urethra, which tunnels through the prostate. These two black lines represent levator ani muscle, which is related to the lateral surface of the prostate. This is a sagittal section of male pelvis. Again, you will have to identify the structures and name them. This is the anterior surface of the prostate. This is lower part of the posterior surface of the pubic. This is puboprostatic ligament which supports the prostate. This is retropubic space. This space is filled with fat, puboprostatic ligament, and it also contains venous plexus. Posteriorly, we have rectovesical fascia. Rectovesical fascia of Denonvillier, which separates prostate from rectal ampulla. Now let us go to the lobes of prostate. Prostate is traversed by urethra anteriorly and ejaculatory ducts posterior inferiorly, dividing this gland into 5 lobes. These lobes are anterior lobe of the prostate, which lies anterior to the prostatic urethra; posterior lobe of the prostate, which lies posterior to prostatic urethra, and superiorly we have ejaculatory ducts. Then median lobe of the prostate and 2 lateral lobes of the prostate. Anterior lobe of the prostate lies anterior to the prostatic urethra. I want to know from you why this lobe is not involved in glandular hyperplasia or in malignancies. The simple called Uvula Vesicae. The enlarged middle lobe of prostate causes an elevation in the mucous membrane behind the internal urethral orifice called the uvula of urinary bladder, as shown by this encircled area. Uvula Vesicae produces urinary obstructive symptoms like dribbling of urine, frequency of micturition, increased urinary urgency, and nocturia. It is diagnosed by ultrasonography. Posterior lobe of the prostate is located behind the urethra, posterior inferior to the ejaculatory ducts. It is commonly involved in malignancies of the prostate. Again, the reason being it contains lot of glandular tissue and mostly malignancies are arising from the prostate or of adenocarcinoma type. That means malignancies arising from glands. There are 2 lateral lobes of the prostate, right and left lateral lobe. These lobes lie on either side of the prostatic urethra. They are separated from each other by a shallow vertical groove on the posterior surface of lateral lobes also contain many glands. Now if we go to the structure of the prostate, as already said in the definition, it's a fibroglandulomuscular structure. That means it is composed of numerous glands as shown in this figure. and fibromuscular tissue. So inside the prostate, we'll find a lot of fibrous tissue, muscular tissue, and glandular tissue. The ducts of these glands open in prostatic urethra. Now coming to the capsules of the prostate. Prostate is enclosed in two capsules. One we called as true, another false capsule. True capsule of prostate, it is inner capsule adherent to prostate. This capsule is derived from condensation of peripheral connective tissue. Outer capsule is called false capsule. It is derived from pelvic fascia and is continuous with viboprostatic ligamentous anteriorly, true ligamentous of bladder and rectovesical fascia posteriorly. The prostatic venous plexus lies between these capsules. So here in case of prostate, venous plexus lies between the true and false capsule. Let's again go for a buzz differentiate between capsules of prostate and capsules of thyroid gland. In thyroid gland, venous plexus lies deep the true capsule, whereas in case of prostate, venous plexus lies between true and false capsule. Surgical importance is that during thyroidectomy, gland is removed along with the true capsule, whereas in case of prostate, adenoma is shelled out, leaving behind both capsules and venous plexus between them. Like prostate, thyroid gland is enclosed in two capsules. True capsule surrounds it. False capsule is derived from pretracheal layer of deep cervical fascia. Now this beautiful animation will make things clear for you. Thyroid gland is surrounded by true capsule which is derived from condensation of the connective tissue. Then outer capsule is called the false capsule which is derived from pretracheal layer of deep cervical fascia. Thyroid venous plexus lies deep to the true capsule. So during thyroid surgery, what we do, we give an incision and we take out thyroid gland along with true capsule, venous plexus, and leaving behind only false capsule of the gland, as shown in this animation. Now coming to the prostate, it's also enclosed in the true capsules. True capsule, as already said, is derived from condensation of the connective tissue. False capsule is the outer capsule. It is derived from the pelvic fascia. Venous plexus lies between true and false capsules. During surgeries on prostate, we shell out the adenoma. We give an incision, shell out an adenoma, leaving behind both capsules and intervening venous plexus. Denonvillier fascia, the plane between wind and water, lies posteriorly adherent to the prostate. Between it and rectum lies posteriorly adherent to the prostate gland. It separates prostate from the rectum. Anteriorly we have prostate gland, posteriorly we have rectum. The two are separated by fascia denonvillier. Also covers the posterior surface of the seminal vesicle. The functions of this fascia are that it forms an important barrier to the spread of prostatic and rectal malignancies. Zonal anatomy of the prostate. From morbid anatomical perspective, the glandular tissue may be subdivided into three zones. These zones can be identified with transurethral ultrasound. The zones are transition zone, central zone, and peripheral zone. Transition zone, it lies around the distal part of the preprostatic urethra, as shown in this diagram. This is the smallest zone of the prostate, contains about 5% of glandular tissue by volume. It is separated from rest of the glandular compartments of the prostate by distinct fibromuscular bands. Benign prostatic hyperplasia is most commonly seen in the transition zone. Central zone of the prostate surrounds the ejaculatory ductus posterior to preprostatic urethra and is more or less conical in shape with its apex at the Verumontanum. This zone expands towards the base of the bladder surrounding the ejaculatory ductus in the shape of a cone. Peripheral zone of the prostate is cup-shaped and encloses the central and transition zones. This is the largest zone of the prostate, accounts for 70% of glandular tissue makes up posterior and lateral aspects of prostate. The ducts of the peripheral zone drain into the prostatic sinus. Let us go for a buzz to describe the zones of the prostate. B zone of prostate is demarcated by this arrow. It is a cup-shaped zone of the prostate surrounding both central and transition zones. So it is peripheral zone of the prostate. Now this zone of the prostate, as shown in diagram, it surrounds the ejaculatory ducts. It is cone-shaped and is surrounded by the peripheral zone. So the zone is central zone of the prostate. Now this zone of the prostate, as shown by this arrow, surrounds the pre-prostatic urethra. So this is transition zone of the prostate. And interiorly we have anterior region of non-glandular tissue. Structures within and around the prostate. Urethra is divided into three parts. We have prostatic urethra, membranous urethra, and spongy urethra. There are two sphincters, internal sphincter called sphincter Vesicae at the neck of bladder and external sphincter or sphincter urethrae. Prostatic urethra is 3 to 4 centimeters in length. It tunnels through the substance of prostate closer to the anterior than posterior surface and emerges from the prostate slightly anterior to the apex. Prostatic urethra begins at the neck of the bladder. It is continuous with pre-prostatic part of urethra superiorly. It tunnels through the prostate from base to apex, where it becomes continuous with membranous part of the urethra inferiorly. Interior of the prostatic urethra. It is the widest part of the urethra. On the posterior wall of prostatic urethra is a longitudinal ridge called a urethral crest. Prostatic sinus is a groove on each side of this ridge. Prostatic glands open in prostatic sinus. Ejaculatory ducts open on the summit of the urethral crest. To make the things more clear, so again there is a buzz time to describe the interior of the prostatic urethra. So identify this urethral crest. It projects from the posterior wall of the urethra and runs throughout the length of this wall. What is this? This prostatic utricle. Below the prostatic utricle, we have two openings. These are openings of ejaculatory duct. The elevated area or summit in the middle of prostatic crest is called seminal colliculus or verumontanum. On either side of the verumontanum, we have many openings for prostatic glands. So these are the openings of prostatic ducts. This encircled area represents uvula vesicae. It is an elevation produced on the trigone of the urinary bladder due to enlarged median lobe of the prostate. Again, this red encircled area represents verumontanum or colliculus seminalis. Colliculus seminalis is an elevation at the middle of the length of urethral crest. It contains slit-like orifice of prostatic utricle proximally. On both sides or just within this orifice are the two small openings of ejaculatory ducts. Arterial supply of the prostate is mainly supplied by the inferior vesical artery, which is a branch of internal iliac artery. Other sources of blood supply are middle rectal and internal pudendal artery. Venous drainage of the prostate is very important clinically. The prostatic venous plexus lies lateral to the gland and receives dorsal veins of penis. Superiorly, this plexus joins the vesical venous plexus around the neck of bladder. This plexus generally drains laterally and posteriorly along the inferior vesical arteries into the internal iliac arteries. Some veins drain into the external iliac veins. Let us make this discussion very simple. Prostate is drained by prostatic venous plexus. The main tributaries of the prostatic venous plexus are we have the dorsal vein of the penis, and near the neck of the bladder we have the vesical plexus. Now these plexus together drain laterally into the internal iliac vein, but some of the veins drain into the external iliac vein. As shown in this diagram, we have prostatic venous plexus. The veins of the prostate drain into prostatic venous plexus, which is very important clinically. The tributaries of this plexus are dorsal vein of the penis, also vesical venous plexus draining into the prostatic venous plexus. From there, venous blood goes into internal iliac vein mainly, but some blood also drains into external iliac vein. Now, what is Batson's plexus? It is a network of veins with no valves that connect the deep pelvic veins draining the bladder, prostate and rectum to the internal vertebral venous plexus. This explains the spread of malignancy from prostate to the vertebral column. Lymphatic drainage of the prostate. Lymphatics begin largely or entirely within the capsule, not in the prostatic tissue, explaining the spread of malignancy by veins, prostatic vessels, and mainly in internal iliac, sacral, and obturator nodes. Innervation of the prostate. It is supplied both by sympathetic and parasympathetic nerves. Parasympathetic nerves are derived from pelvic supraspinatus nerves via inferior hypogastric plexus. Sympathetic nerves originate in L1 segments of the spinal cord and reaching the gland through hypogastric plexus. They supply the smooth muscle of the prostate, seminal vesicle, and vas deferens. Sympathetic nerves are responsible for ejaculation. The striated muscle inside the prostate is innervated by pudendal nerve. Applied anatomy of prostate. Clinical examination of prostate, also called DRE, digital rectal examination, gives idea about the size and consistency of prostate. Benign hypertrophy of the prostate commonly involves median lobe of the prostate. It leads to syndrome of symptoms called prostatism. Malignant tumors usually involve the posterior lobe of prostate. Prostatic malignancy can spread to the vertebral column through Batson's plexus. Per rectal examination, we divide the prostate into different grades. In grade 1, upper pole of the prostate is easily reachable. In grade 2, upper pole of the prostate reaches with difficulty. In grade 3, we cannot reach the upper pole of the prostate. I want to summarize my lecture as under: prostate is a pyramidal fibromuscular glandular structure. It is located between bladder above and urogenital diaphragm below. Its secretions add to the volume of seminal fluid, which is secreted by seminal vesicles. It has a base, apex, and four surfaces and five lobes. Prostatic urethra tunnels through prostate and receives ejaculatory ducts. Prostate is involved in inflammatory, benign, and malignant diseases. Now let us go for a quiz to check our knowledge. In this quiz, you will be given an MCQ with 4 options. You have to find the most correct option. Our first question is: weight of the normal prostate in young males is: A is 8 to 15 grams, B is 18 to 20 grams, C is 20 to 25 grams, and D is 25 to 13 grams. The correct choice is B, 18 to 20 grams. I will not go for A because A is the weight of prostate in cadavers, but in the question I mentioned young males, so it is 18 to 20 grams. As already discussed with you that weight of various viscera is different in living and cadaveric state. Next question is: true statement about prostatic venous plexus is: it lies between the true and false capsule, B is deep to the true capsule, C does not communicate with Batson's plexus, D is removed along with the prostate to avoid hemorrhage during prostatectomy. True is it lies between the true and false capsule. Next question is: which of the following structures is not related to the anterior surface of the prostate? A is prostatic venous plexus, B is puboprostatic ligament, C is fascia of Denonvillier, D is posterior surface of symphysis pubis. Obviously answer is C, fascia of Denonvillier. This question is based on the innervation of the prostate. Dry coitus, also called retrograde ejaculation, is caused due to lesion of sympathetic nerves, parasympathetic nerves, due to the lesion of L1, or due to the lesion of L2. It is the sympathetic nerves which are responsible for ejaculation, but the exact nerve which is involved here is L1. L1 supplies prostate, so it is the lesion of L1 which causes retrograde ejaculation. Next question is, Verumontanum is located at which part of the urethral crest? Is junction of upper third and lower two third? Junction of lower third. B is junction of lower two third and upper one third. C is middle of the urethral crest. D is lower fourth of the urethral crest. So I will go with the C. Commonly involved lobe in benign hypertrophy of the prostate is anterior, posterior, median, and lateral. Answer is median lobe of the prostate. Commonly lobe involved in the malignancy of the prostate is anterior, posterior, median, lateral. The correct answer is posterior lobe of the prostate. Which lobe is not involved in malignancy of the prostate? Anterior, posterior, median, lateral. Anterior lobe is not involved in the malignancy of the prostate. The reason I have already discussed with you is that it does not contain glandular tissue. So it is neither involved in the benign or the malignant conditions of prostate. By definition, the last question is, by definition, prostate is a dash gland. Parvomuscular, fiboglandular, musculoglandular, fibromusculoglandular. The correct answer is D. As already defined, prostate is composed of fibrous, muscular, and glandular tissue in different proportions. Thank you for watching this video. To see more videos, do not forget to subscribe this channel. Press on the bell icon to remain updated about channel uploads.
Do not forget to subscribe my channel. Press on the bell icon to remain updated about more video uploads.